What we're talking about today is exploring the limits of non-surgical class 3 treatment. Half an hour is really not a lot of time for this subject, so I hope you will excuse me. I'm going to dispense with foreplay and jump right in. Would you consider treating this malocclusion without jaw surgery? How about this one? Or this one? And if yes, how would you approach these cases? That's what we're going to be talking about today. So how is it that I come to be speaking on this? Well, my partner, Dr. Sharon Nguyen, and I practice in Scarborough, Ontario, which is a community inside of Toronto. And we have extreme ethnic diversity in our community. So we see a lot more class 3s than the average North American practice would. And most of these people are recent immigrants to the country, so social conservatism makes them less likely to want jaw surgery as an option, despite the relative accessibility in our really awesome Canadian healthcare system. Also, I like this stuff. Okay, so let's set some ground rules. These are my ground rules. The final result has to look natural. It has to look like it could exist in nature. That face you're looking at there has not had treatment and actually has a natural, existing, really nice class 1 occlusion. Compensation is not a bad word. It's what nature does when people don't have orthognathic skeletal patterns. Generally speaking, in this presentation, we're talking about moving teeth. We're not talking about TADs and mini plates or anything like that. We can, of course, rotate the mandible backwards by extruding molars. And this is also important. Last year, I saw a bunch of cases where teeth were outside of alveolar housings, and I don't think that's natural or normal, and our previous presenter would probably agree with that, because that can't be good for roots. Okay, if you were in this room yesterday, you saw this table, because Duncan was talking about it with respect to natural compensation of class 2s. And I'm using the same table from the landmark article by Casco and Shepard. And this was a study of 79 naturally occurring ideal occlusions in Caucasian adults. And it shows the variability in skeletal patterns. So from the standpoint of class 3s, you could have an A and B as low as -3. You could have upper incisors as high as 120. You could have an IMPA as low as 83. And I would say this is a Caucasian study, so if you're dealing with other types of people, you could probably push those numbers a little bit. So that is like the outer limits of what we're talking about. Also from the study is this table which shows, very importantly, the pattern of accommodation for the occlusal plane. With respect to class 3, naturally occurring class 1s, the occlusal plane has to be flatter the lower the A and B gets. That's really important. Okay, let's get back to Diba. Diba is a dental assistant in the office next door, and she came to see us because she was concerned about her proclined upper incisors. Very attractive young lady. Let's take a closer look at her face, though, and put the numbers up there. So you can see that she has a pretty significant brachyfacial skeletal class 3 pattern. Her upper incisors are proclined, and let's see if I can get this to work. Take a look at her occlusal plane. See how tipped up it is? But here are her teeth. She got pretty nice teeth. Nice class 1 occlusion, a little bit of spacing on the top, very minor irregularity in the bottom. So I said to her, Diba, you're right. Your upper incisors are proclined, but it's natural and normal for your skeletal pattern. Unless you want to change your jaws, you should just leave your teeth. And I chose not to treat her. Well, luckily for us, most people with skeletal class 3 patterns do need treatment. They don't come in with normal class 1 occlusions. So we have 3 basic ways that we can fix them. We can move the teeth by moving the upper arch forward, lower arch back. We can increase vertical dimension by extruding molars, rotate the mandible back. And we can rotate the occlusal plane counterclockwise. My favorite part is you can combine all of these, though. You don't have to just stick to one. Let's look at the first, which is arch compensation. This is Neil. Neil comes in looking to have treatment for his negative overjet. You can see on his pictures that he has a pretty significant skeletal class 3 pattern. But these are his teeth. And I have to pause for a minute here because this is one of my pet peeves. Neil has got the exact kind of case I often see in the literature when people talk about non-surgical compensation of class 3s. The problem here is that Neil is not a class 3. He has a class 1 malocclusion. Look at his buccal segments. They are solidly class 1 the way Angle defined them. He's got negative overjet, but that doesn't make him class 3. Why does he have negative overjet? He has negative overjet because his upper incisors are retroclined, lower incisors are proclined, and his upper incisors are crowded. So it should come as a surprise to no one that this would actually be a really easy case to fix. In fact, Sharon and I did this with Invisalign, a little bit of IPR on the lower. It took about 18 months, and not a single class 3 elastic. We're not going to show any more easy cases like that. This is a real class 3. This is Melanie. And I don't think you need to be an orthodontist, there's some non-orthodontists in the group here, to know that her vertical dimension is overclosed. Look how deep her bite is. Look at the redundancy in her lips. Let's take a closer look at her malocclusion. Pretty significant. Family decided they did not want surgery here, so the only option I have is to increase the vertical dimension. And we spent about 2.5 years doing that, and this is where we got her to. Here's some teeth. And this is Seth. And this is a mantra that I want you to be thinking about when we're compensating skeletal class 3s. We want to have the upper arch forward, lower arch back. We want to have that occlusal plane flat. Final strategy is rotation of the occlusal plane. We're not going to show a case here. We're going to show a figure from one of my favorite books by the late Dr. Burstone and Dr. Michael Marcotte. This is figure 3.8. And if I could leave this up for 5 minutes, I would, because it's a really powerful figure. In the figure, the skeletal bases are not changing. But if you look up here at this one, you see how rotated back that occlusal plane is? That makes the pseudo-width analysis quite class 2. So we want to do that if we're compensating class 3s. And what Duncan's appliance does is exactly the opposite to compensate for class 2s. It rotates the occlusal plane. Well, that's easier said than done. But now that we've done all the intros, we can move to the primary subject of this presentation, which is perhaps the most feared malocclusion in orthodontics, the class 3 open bite. And I actually love treating class 3 open bites, and I'm hoping that in the time we have left, I might make you guys more comfortable with it too. Okay, created a checklist for non-surgical compensation of class 3 open bites. First thing on the checklist is growth. You can't be treating people who are growing. It's like running a marathon on a treadmill. You're not going to go anywhere. Face has to be acceptable, I guess, to you and to the family. Skeleton. You got to be able to put those teeth where they still have bone around them and they're not through the cortical plates. The next two are related, and I'm not going to read them. I'm going to let you guys read them while I take a little bit of water. We're going to spend a lot more time talking about those last two. Okay, so now we're going to look at some cases, and we're going to look at cases which roughly approximate my journey of discovery for this type of treatment. We're going to look at the first, the favorite, and now what I call the familiar. And the first significant class 3 open bite that I ever treated non-surgically was Ronald. This was Ronald when he came in 2001. And you can see somebody had already done some phase 1 and relieved him of a couple upper bicuspids. And this is how he came to see me when he was 17 and a half. And Ronald had already had 2 other opinions which said he needed surgery, which seemed quite reasonable to me at the time. But his family absolutely did not want that, and they came to me seeking a 3rd opinion. So I didn't promise them anything, but I said I'd take a look. There's his Seth, and here's his panoramic. So I think everybody has a good idea of what's happening in this case now. So while I was working up the case, I kept getting stuck on this picture. I kept looking at that face, and I'm saying to myself, well, if I saw that face, I don't know, at Universal Studios, I would not expect to see this occlusion attached to that face. So I was thinking there may be some way that we can get his teeth to look like how other people would, that face would have normal class 1 teeth. And at the time, I was reading a lot of Mew Technique by Dr. Young Kim. I'd even tried a few, not so well. I had a lot of trouble with the curves and the loops and all that, so I wasn't planning to do that for him. But I thought that maybe I could use some of the ideas attached to the Mew Technique to make Ronald's teeth better. So you might want to know, like, well, how did that work out? How did that something else work out? Well, I think it actually worked out pretty good. I was really happy with this. Ronald was an exceptional patient. He did everything I asked him to do. It worked out really nice. So your next question might be, well, how did it hold up, Anthony? That's a good question. And I say, well, not so good. Here he is after he stopped changing. He lost about, I would say, 30 to 40% of the correction. He's still a happy guy. His teeth are completely straight. He didn't need surgery. All his teeth touch. And depending on your perspective, you might call this a qualified success or an abject failure. I'm somewhat of an optimist, so I kept tooling around with it. So I kind of refined the processes a little bit, so I was much more ready when Candace came in with her mother. And Candace is a favorite. Very pretty young lady, almost 14. And her mom is a medical reporter by profession. Let's take a look at her Ceph and panoramic. So Candace, once again, had a couple other opinions that she needed jaw surgery. Again, pretty reasonable by current orthodontic standards. But her mom, being a medical reporter, did her research and said she did not want that for her daughter. And I could really see her point, because this was a very pretty young lady, despite her skeletal class 3 pattern. So let's go back now to the checklist, thinking about Candace's face. She clearly wasn't growing. She had secondary sex characteristics, hadn't changed any sizes in over 2 years. I wasn't worried about that. Clearly, I wasn't worried about her face. And I could imagine pretty easily those upper incisors going a bit more forward, or those lower incisors going a bit more back. And she clearly had divergent lower occlusal planes. Her upper occlusal plane is pretty flat, but her lower occlusal plane in the buccal segments does not approximate it. And consequently, she has mandibular apices that are distal down here of her crowns. Let's talk a little bit more about apices. Class 3 open bites often have mesial tipped lower buccal segments, which means that the apices are less class 3 than the crowns. I don't have a cone beam. I diagnose this with handheld models and Cephs usually. Panoramics are not nearly as predictable for tip. So this is not my case. This is a colleague's case. I was visiting his office, and this person is scheduled for jaw surgery, which I think is very reasonable because I can't imagine compensating that. It's like an 8mm class 3. But I want you to look more carefully at these teeth here. Look at the 6, look at the 5, look at the 4, look at the 3. They are all leaned forward like a wind has blown them. And if those teeth were upright over their skeletal, over their apices, then that 8mm class 3 would probably be a 4mm class 3. So let's get back to Candace. If I'm going to compensate her, I need to put an extrusive force at her lower premolars, and I need her lower occlusal plane to rotate with a center of resistance approximately at the distal of the lower 6. And if I do that, then maybe her lower buccal segments will rotate distally with their center of rotation approximately at the apices, and maybe she could be class 1. I only know one way to do that. It's to take out the lower second molars. Now, you might say, whoa, Anthony, I was following you right until you said take out lower second molars. Why can't I just take out some bicuspids instead? Well, you're just going to make the lateral open bite worse if you do that. It's a pretty crude animation. I'm going to try and explain it. The green line approximates the occlusal plane relative to the lower molar. And we take out the first bicuspid and we put space closing force on that. The lower molar is going to want to tip forward, and it's already tipped. The lower occlusal plane is going in the wrong direction. I don't want to do that. Mesially tipped lower molars want distal force, not mesial force. And those 3 exclamation marks are for you, Dara. All right, we're doing something else. Here's what I did. First appointment, we put her braces on, whole upper arch. I put segmental braces on, only on the lower, 6 to 4. I wrote a note to the dentist to get the second molars out. Second appointment, she came back. We put a wire in on the buccal segment. And then I said, Candace, now's your time. Wear those elastics. I gave her elastics, told her to wear them full time, class 3, in the direction of those yellow arrows. And the next set of pictures are what her teeth look like the next time I saw her, third appointment. Now, I'm going to leave this up for a little while. I want you guys out there to pick any lower anterior tooth on the top with no braces and look at it on the bottom to see how it's moved on its own, compensated naturally in response to the buccal segments. Now, that's pretty cool. If I asked her to stop, that would move back. She had to keep wearing the elastics. But when I see her this day, I know that this case is basically done. And I kind of ran out of stuff at 22 months, and I took her braces off. This is the day her braces came off. So you might be curious about some of the rest. Here's the Ceph shortly before D-band. Face at about the same size. You see upper arch forward, lower arch back, occlusal plane flat. Well, what about those wisdom teeth? Well, there's a Panorex shortly before D-band. And this appliance is an anchor appliance, which is going to allow me to be able to line those wisdom teeth later on when they come in a little bit more. So maybe a little less than a year, they came in enough that we put some braces on and ran some segments and lined up the wisdom teeth. And then I set her free after a couple of years of observation. She goes on, grows up, becomes a school teacher, and gets engaged and brings her fiance in for treatment. We treated him with Invisalign. And they were both in recently. They're now married. And I asked her if I could snap some more pictures. So what you're going to see here is the lower arch from 6 months ago, 7.5 years after D-band. See the wisdom teeth looking pretty good. There's that beautiful face that probably could never have been improved with jaw surgery. And here are the teeth. Okay, so that was a favorite. So what was that something else? The something else is now what I would call the mechanical muss here. And these are really important. You got to extract that lower posterior wheel block. This is a phrase I got from my buddy Cappy over there. It just helps those teeth to roll back into place. You got to take that out first before you put the lower wire in. You got to start with sectionals on the lower, and I'll explain this a little bit later. Class 3 elastics immediately after posterior extractions. Class 3 elastics are actually better than class 2 elastics because they do everything you want. You do that, they do that, they do that. And increasing vertical dimension is not generally a good thing in class 2s. Then the last thing is you pick up the lower anteriors after everything else is taken care of. That's the recipe. Okay, excuse me, I'm going to take a little bit more water. This is Hannah. And she is the niece of a good referring dentist. And we'd been watching her for a couple of years when these pictures were taken. So I knew that she wasn't growing anymore. There's her Ceph. Those are her bite. You can see the class 3 is definitely worse on the left than it is on the right. There's a Panorex. I'm sorry, those elaborate earrings just would not come out. So let's look at a checklist here. Definitely not growing. I'd been watching her. I knew she had stopped. Face is acceptable to the family. They're absolutely not interested in jaw surgery. Skeleton, for sure, I could imagine that being compensated. Occlusal planes, you can clearly see that this occlusal plane and that upper occlusal plane are not coincident. And as a result, you can see the apices over here too. So why not take upper 5s and lower 4s here? It kind of looks like that would work out. Well, I don't want to do that either because I want to keep my upper arch forward. I need a little bit of space, but I don't want to take out upper 5s because I'm worried my upper arch is going to go backwards. And I don't want to take out lower fours either because this molar is tipped this way. It doesn't want to go this way. It wants to go that way. So this to me is an obvious case for extraction of all 4 second molars. Change the protocol a little bit nowadays in that I don't start full-time class 3 elastics all right away. So there she is at 8 months. I wait till the upper arch is fully aligned before we start full-time class 3s. So she was wearing nighttime light class 3s just to kind of tease the teeth back a little bit. But you can see we already have improvement in the lower anterior segment. Then once everything's lined up upstairs, we put stronger elastics and we go full-time. And this is henna after I ran out of stuff to do. I'm going to leave this up for a little while so everybody can find something wrong with the pictures or with the finish. This is the day. Find anything yet, Ray? That's my favorite thing to do. All right. But look at this. This is a pretty cool improvement in profile. Unexpected, really. And I don't think we would have gotten this had we taken out bicuspids here. Okay. This is Trey. And he's also got that kind of paradoxical face that you don't expect to see a class 3 open bite. And yet, there it is. There's his occlusion. And I had a problem here. We have an ectopic cuspid on the left. That's not the problem. We have an impacted cuspid on the upper right. This dude is only 13 years old. He's definitely still growing. But I'm a little concerned about that impacted cuspid. So let's run through the checklist here. He fails the first one, and ordinarily I would just watch him until he will stop growing, but I can't because I'm worried about that cuspid. So I only watched him for a year, and because I knew he was going to be growing in a way that was not favorable, I wanted an aggressive extraction pattern so I could manage it. So once again, he had all 4 second molars removed. Remember our mechanical muss. So here he is at 8 months showing his true colors. We've expanded the upper, we're making space for the upper cuspids, and now he really is quite class 3 open bite, isn't he? But I'm not worried about this because I'm going to ask him to wear heavier elastics once I pick up that upper right cuspid, and I'm going to tip that buccal segment back. So this requires a little bit of explanation now. Imagine, where are we? Imagine if I had brackets over here and this wire went all to those brackets. What's that going to do? It's going to make the open bite worse. It's not what I want. That's why I left them off. 8 months later, it's safe to engage them because my buccal segment has uprighted distally into the space of the wheel block. You got it, Karen? All right. So here he is. Davey took his braces off. Those are his teeth. You can actually see the wisdom teeth. Well, on the previous picture, you could see them sneaking in. And there he is 14 months later. He had a little bit of movement of his upper right cuspid, the one that was impacted, and we handled that with IPR and a new Holly. But look at his buccal segments. That's really what we're talking about here. His teeth are together, solidly class 1. They're not going anywhere. It's stable. Okay, last case. I can go a little slower because I have a little time now. This is Aabira. This little cutie comes in. And again, her face kind of belies her malocclusion. It's a pretty significant malocclusion. Now, at the time she first came in, she was 12. So clearly she fails the first on the checklist. She's still growing. So what Sharon and I do, patients come in, we take their height, and we look at their buccal segment occlusion, and we send them off. And we don't really consider treatment until their height stops changing and their buccal segments are stable. And Aabira is interesting here because her left is worse than her right. But in the 3 years that we were monitoring her, her rights got worse and her open bite got worse. And now, if you're all ready, I'm going to play the slide and you're going to see what she looked like 3 years later. So if I had started her at age 12, that would have been my fault. I would have been responsible for that. Now, this is a pretty wicked class 3 open bite, isn't it? Let's go through the checklist. Well, there's her face. You can see, I mean, when I look at that face, I think it could benefit from jaw surgery. That lower lip is full. Those are teeth you just saw. There's a ceph. That ceph gives me pause too. Spanrex. Look at the upper second molars, completely over-erupted because they're not occluding with anything. And there's that left buccal segment. So let's look at the checklist. Well, I'm not worried about growth anymore. I know she stopped growing. I did my due diligence on that. I have a question mark on the face. I encouraged her family to go seek an opinion at the jaw surgeon. But turns out they have a family friend or somebody close to them who had jaw surgery and had an unfavorable outcome with complications. So they're not remotely interested in it. And they say, doctor, we don't want to do surgery. Whatever you can do without surgery, that's what we want. Occlusal plane is fine. You can see she's got divergent occlusal planes. Apices is a bit of a question mark too. So I want to spend a little bit more time on this case so you can follow the thought process here. When I'm looking at her over here, her upper incisors are already quite proclined. I can't get much more compensation out of those. I have to take that off the list. Her lower incisors could probably come back a little bit, but not that much. The majority of the correction here, if it's going to work, has to come from occlusal plane rotation. Then I'm looking at this left buccal segment, and I'm looking at apices. Originally, I thought I was going to take out 4 second molars here. But when I'm working up the case, I'm looking at it. I'm okay with the 4 and the 5. They're tipped a bit. But this 6 is upright. It's not tipped mesially. And if I put a class 3 elastic on this and tip it back to be class 1 with this 6, it's not going to be stable. That's what I screwed up with Ronald. I figured it out much later. This 6 right here is the wheel block, Dr. Jason Kaplan. So that 6 has to come out. So what we did is we took out those over-erupted upper second molars, so I don't have to spend any time pushing them back up there. And we took out the lower first molars. And here she is at 12 months. Now, she wore the class 3 elastics just nighttime to help those teeth roll back into place. We weren't doing it full time because I didn't really want the upper teeth to go much further forward. I can finish this case now. There's a ceph. I think it's pretty powerful ceph comparison, 12 months. Look at that occlusal plane rotation. Now, this to me is the outer limit. I mean, those lower incisors are pretty upright. They're standing, pretty much right where they can. They can't go any further back. This is my outer limit. But she's got the mantra. Her upper arch is forward, her lower arch is back, her occlusal plane is flat. Okay, there's the panoramic shortly before D-band. That's what she looked like the day we took her braces off. Had some brackets left on the lower right because I was waiting for the upper wisdom teeth. And these are the last set of pictures I had, 15 months post D-band. Holding up quite well, actually. Not expecting this to change significantly. Okay, does this work all the time? What do you know that works all the time? If I told you that, you'd know I was lying. So usually if it doesn't work all the time, the times it doesn't work is related to the checklist. If you start too early, patients can outgrow whatever you're doing. If they're not wearing the elastics, your occlusal plane is not going to rotate. And I have seen this, it's rare, but if they have the thin biotype, you can see recession. Okay, we're almost done. I got 1 minute and 22 seconds left. Class 3s with reasonable facial balance do not always need surgery. Mandibular molar extraction and occlusal plane rotation are powerful tools to emulate natural compensation in the class 3 open bite malocclusion. Taking out lower second molars is really awesome. It really is my favorite way to do these. Very, very predictable. And if I can do it, you can do it. There's no crazy loops, curved arch wires here. You notice they were all straight. So that was it. That is me. That's my email address. If you're interested in this and you have questions or you'd like a PDF of the presentation, please email me and I'd be happy to send you a copy or respond to your questions. And I have to thank my buddy Dr. Paul Halpert in absentia for crafting this presentation. Thank you very much for your attention.